Welcome to the Nurse Station. My name is Maria Mobley, and today we are going to learn about acute kidney injury. As always, these videos are for educational purposes, and I really hope they're helping you future nurses. So acute kidney injury is very different from chronic renal failure or chronic kidney disease. So be on the lookout for a video coming on that, but when we're talking about acute kidney injury, we're talking about the kidneys are hurt in a very rapid onset. And why I love teaching this content, I know I say I love teaching everything in every video, but the cause or the trigger to this acute kidney injury really facilitates your critical thinking. It really facilitates the assessment that the client's going to present with. It's really going to facilitate the interventions that you have to know how to do as a nurse. So that's what we're really going to focus on a lot. So let's first off think about what the kidneys do. They do so many things. I only drew a picture of one kidney, which I'll talk about in 1 second. But kidneys maintain fluid and electrolyte balances. They have the ability to excrete electrolytes. They have the ability to retain water. They have the ability to trigger your RAS system. You remember that whole system from A&P, renin, angiotensin, aldosterone system. Don't quote me on that. You can Google it. Can't remember the full name. Acid-base imbalances, excretion of toxins, regulation of blood pressure, and erythropoietin is stimulated from the kidneys, which helps produce red blood cells in the bone marrow. So the kidneys do so many things. So when we start to have damage to our kidneys, this can result in very serious complications and potentially death. So, as I said before, I'm really going to facilitate your critical thinking to realize, hey, what triggers the problem, what is the onset, which we'll talk about our phases in just a second, really determines how the client's going to present and really determines your intervention. So always remember in nursing, your nursing process, ADPI, right? Assessment, diagnosis, planning, intervention, or implementation. They're universal in evaluation. But in these NCLEX style questions, they really focus on assessment versus intervention, okay? So I'll walk you through all of that. So I want you to start thinking about the phases of acute kidney injury, which there are 4, and how the client looks in each phase, all right? So phase 1 is the onset. And the onset phase, I want you to think, what is the cause? So every book, all your NCLEX resources will break it down into 3 major causes, okay? So my drawing over here, which I worked really hard on, my students can attest that this is good for me. I want you to think about how the kidneys work, okay? So of course, every organ is perfused with an artery that gives it oxygenated blood so it can work, so it can function. So we got our renal artery that's perfusing our kidneys right here that the nephron filters and excretes toxins and reabsorbs nutrients or things that we want to keep in our body. And then a byproduct of all this is urine. So the urine goes from the kidney into the ureter, which is attached to your bladder, and then your bladder is kind of a storage or reservoir for urine, which then eventually the urine is excreted through the urethra. So that's your basic A&P, okay? So the causes of acute kidney injury could be threefold. So I put an A, and we're going to talk about each one. A, look, is occurring before it even gets to the kidney. So when you think of a cause or a reason for acute kidney injury, and this is called a pre-renal cause, I want you to think decreased perfusion to the kidneys for whatever reason. And let's think about it. Every tissue, every cell, everything in our body needs oxygen, right? So if we have decreased perfusion to our kidneys, meaning lack of oxygenated blood flow to the kidneys, won't that result in problems? And there's so many reasons why this can occur. I listed a few, but think hemorrhage, a gunshot victim, right? They have a gunshot wound, they're hemorrhaging dramatically, they have low blood volume, little oxygen circulating in their body. What are you going to do to cope? And I always say I'm talking like we have acute kidney injury, but we are going to cope by shunting any little oxygen left to our vital organs, our heart, lung, and brains, right? Kidneys are vital, I know, but in this life-threatening moment, right here, right now, if it's between sending oxygen to my kidney versus my heart, lung, and brains, I'm going to send it to my heart, lung, and brains every time. Okay, that's shunting of blood. Dehydration is very similar, and shock, same thing. If you have low fluid volume or low blood volume, where is that oxygenated blood going to go? Where is your body try to shoot it to? It's always going to try to get it to your heart, lung, and brains, because that will kill us the quickest if we don't get oxygen to those organs. So those are some causes. So of pre-renal, okay? So this is one of our onsets or our triggers or our cause. Pre-renal, you think lack of oxygen to that kidney, lack of perfusion, and there's multiple causes. Whatever cause your instructor gives you, add it into your chart so you can make sure to be most successful on your tests. The second cause is direct kidney damage. So I put a B right here for your intrinsic causes. I want you to think that this kidney itself, the organ, is damaged for one reason or another. A big cause can be nephrotoxic meds. You remember back to pharmacology, aminoglycosides, those antibiotics, highly nephrotoxic. Contrast dyes, we need kidney function. If we're going to shoot a contrast dye into a client's body, if their kidneys can't filter it out, that's a problem. So those are just a couple examples of medications that can directly damage and hurt the kidneys. You need to think about a kidney infection, pyelonephritis, for example. An infection of the kidney itself can absolutely be an intrinsic cause. And I also put here ischemia. You got to think, if we have decreased blood flow due to a pre-renal cause, and that causes ischemia or damaged cells and tissues in our kidneys are not going to be able to function. So that could be a cause as well for your intrinsic causes. I just want you to think a direct damage to the kidney. And then the last thing that can cause or trigger acute kidney injury is post-renal. So I want you to think everything after the kidneys. So your ureter, your bladder, and your urethra, okay? I want you to think, if we cannot excrete urine, that is going to backflow up into your kidneys. And if it backflows up into your kidneys are going to be damaged. Very similar to heart failure. When your heart can't pump effectively, where can that fluid back into? It could back into your lungs and start to cause respiratory failure. So very similar in patho, okay, in terms of the backing up of fluid that leads to damage. So a couple examples that can occur from this is any bladder injury. There can be tumors, there can be carcinomas, there can be cancer, for instance in the bladder, that can cause a backup of urine. We can have an obstruction of our ureter, our bladder, urethra. A big cause of obstruction could be stones, okay? Kidney stones, for example. Another cause of obstruction, and I did have to abbreviate a lot on this board just to fit it all in, so I'll make sure to always spell out the abbreviations. This is abbreviation, benign prostatic hyperplasia. This is when the prostate for men get enlarged. So think about where the prostate would be located. It would be right behind this urethra. If that gets enlarged, can it put pressure on the urethra and urine not be able to escape? If that urine can't escape so that we can avoid it, isn't it going to back up to our kidneys and eventually cause post-renal acute kidney injury? So those are the three types of triggers, your three causes. Think pre-renal, intrinsic, post-renal, and keep it very basic. Lack of perfusion, pre-renal. Direct kidney damage, so intrinsic factors. And then a backup of obstruction of urine. So all that urine starts backing up into your kidneys, therefore causing damage, okay? That's your post-renal causes. So those are our causes for acute kidney injury. This is going to directly facilitate client assessment and directly facilitate our nursing interventions, our nursing actions for the care of these clients. So our second phase is called the oliguric phase. So when you think about oliguria or anuria, right, decrease urine production to minimal or absent urine production. So always keep in the back of your mind, what do we need to say that we have healthy urination or we don't have to intervene for urine production? They need 30 mLs of urine per hour. We need to be ensuring that they have 30 mLs of urine per hour. That's just one little medicine cup, if you think about it. to state that they have appropriate urination. Well, in this phase, they are not meeting that criteria. They are not meeting the 30 ml per hour requirements that we need to state to say we have healthy kidney function. So there's a decrease in urine output for one of these reasons, and your signs and symptoms of this phase are completely dependent on the cause. I'll give you first example. Signs and symptoms in FVO is for fluid volume overload. So let's look at our causes, okay? Fluid volume overload, they are retaining so much fluid that we are now starting to get elevated blood pressure, edema, tachycardia, jugular vein distension, that neck vein is sticking out, that's JVD, jugular vein distension, shortness of breath, and crackles, because now the fluid, our heart can't cope with all this fluid that's building up, is now starting to back into our lungs. Well, let's think about this. Signs and symptoms of fluid volume overload, think about your pre-renal causes. If they're hemorrhaging, would they present with signs of fluid volume overload? Absolutely not. They present with signs of fluid volume deficit. What if they're in shock or dehydrated? Do they show signs of fluid volume overload? Absolutely not. When we're thinking about signs and symptoms of fluid volume overload, I want you to think intrinsic and post-renal problems. Now the fluid is starting to back up. The kidneys are starting to fail. So you're retaining all your fluid in urine, okay? That's what I want you to think for fluid volume overload. Changes in behavior is universal for all causes, A, B, or C. They absolutely, your kidneys, a purpose is to excrete toxins. Once toxins start to build up in the body, can't you have confusion? Can't you have fatigue, lethargy, a change in behavior, okay? Next sign is metabolic acidosis. Your kidneys is a coping mechanism for acid-base homeostasis. Remember, kidneys have the ability to regulate hydrogen ion, which is acid, and your HCO3 right here, which is your bicarbonate, your base. So kidneys have the ability to help cope in acid-base imbalances. Well, now that your organ that helps control acid-base imbalances is failing, it will result in an acid-base imbalance. And the acid-base imbalance you need to look for is metabolic acidosis. So if we're acidic, remember pH is 7.35 to 7.45. Acidic means the pH starts to decrease, okay? And also if you're in an acidic state, your bicarbonate, HCO3, which is your base, will start to decrease as well. Because in an acidic state, your base is low, okay? So you need to look for metabolic acidosis. And then you need to look at your labs. Certain labs, and you probably, ask your instructor, I'm sure you will need to know electrolyte levels and lab values if you're taking a test on this content. But let's think about the labs that show kidney function. Let's think about the labs that can show if our kidneys are being damaged or hurt or not working appropriately. Labs that should always pop in our mind is BUN, blood urea nitrogen, and creatinine, okay? That they show appropriate kidney function. And when we start to have our kidneys fail or damage for whatever reason, those BUN and creatinine levels will start to go up, okay? Your glomerular filtration rate, okay? Think about what your glomerulus, I can never say that word right. Glomerulus, I would Google the pronunciation of that one. But think about what it does in your kidneys. Isn't that what filters? Isn't that like your filtering agent to reabsorb what we want to keep in our body and to excrete our toxins through our urine? Well, this is showing kidney function. And when our kidneys are damaged or hurt or not working appropriately, that value will actually go down, showing that we are not filtering as well as we were before, okay? So you'd have a decreased GFR. Your kidneys excrete potassium. Actually, majority of how the body excretes potassium is through the urine. So if our kidneys are failed, little to no urine production in the oliguric phase, aren't we retaining potassium? So you could see hyperkalemia in these clients. Phosphorus is very hard to filter from the body. So the kidneys are damaged. It can't filter that phosphorus out into the urine. So you can see increased phosphorus levels. Well, let's think what is always inverse of phosphorus is calcium. So when we start getting high levels of phosphorus in the blood, you're going to start to see hypocalcemia because they're direct inverses of each other. And if you don't know what an inverse means, just think if they are direct inverses, when a component goes up, the other has to go down. So because the kidneys can't filter phosphorus appropriately, it starts to build up in the blood. Calcium, which is the inverse of phosphorus, so your phosphorus is going up, your calcium is going to go down. So look for high phosphorus levels, low calcium levels, and your sodium. Sodium is really dependent on the cause, okay? So sodium can absolutely be normal. But let's think, if it's an intrinsic cause or a post-renal cause, aren't we retaining all our fluid? We can't excrete fluid through our urine, so we're starting to retain fluid, retain fluid, retain fluid. What is that fluid or water going to do to our serum sodium levels? Is it going to dilute the sodium levels, or is it going to concentrate the sodium levels? Well, we have a lot more water right now compared to sodium particles. So if we have signs of fluid volume overload, we can absolutely have hyponatremia, or a low sodium level. So with sodium, it could be normal or hyponatremic, especially if you have that fluid volume overload, okay? So again, presentation depends on what's going on. You won't have fluid volume overload symptoms if the kidney's not getting perfusion in the first place. If your body is just lacking oxygen and blood flow in general, such as hemorrhage, shock, dehydration, okay? But change in behavior, metabolic acidosis, your changes in your labs are pretty universal for any trigger or any cause of acute kidney injury, okay? So just keep that in the back of your mind. At the end, we're gonna do 2 NCLEX style questions. So you can see, based upon our assessment data, it will absolutely change what type of nursing intervention or nursing action we're gonna do for our clients, okay? So, this is your oliguric phase. I need you to understand treatment needs to occur in this phase. We are showing signs of a problem, okay? In the onset phase, it happens very quickly, you know, a couple hours to less than 2 days, but your body might not be physically showing the symptoms yet. In the oliguric phase, we have physical assessment data where we don't need to gather any more data anymore. We need to act as nurses and act quickly. So I want you to think treatment needs to be done in the oliguric phase. And treatment, of course, will depend on the problem as well. So let's start with decreased perfusion to the kidneys. Look at all these problems: hemorrhage, dehydration, shock. You have fluid volume deficit. So if we help the fluid volume deficit problem, if we give fluids, won't that increase your fluid volume? Won't that help circulate more oxygen throughout your body? And won't it help better perfuse the kidneys to try to stop damage? So fluids, if we're given fluids, a lot of times it's related to decreased perfusion of the kidneys. The fluid solutions you would want to start with are isotonic solutions. So your 0.9% sodium chloride, your normal saline. We don't want fluid shifts. We want to put it right into our circulatory system, and we want it to stay there to replace that volume. Another treatment could be diuretics. Think about it. We have direct kidney damage, or we have this buildup of urine and electrolytes. Diuretics could help promote that diuresis. It could help get, let's say they're having symptoms of fluid volume overload, it could help get those symptoms out, okay? Or I said symptoms out. It could help get the urine and fluid out of their body. So whenever we need diuretics for rapid diuresis, you need to think your loop diuretics. That's your furosemide, aka Lasix, but remember for the NCLEX you need generic names. So your furosemide or your bumetanide, okay, aka Bumex, but you need to know your generic names. Other treatment could be devices. Let's think about it. Post-renal causes. We have a prostate obstructing our urethra, okay? Urine can't get past that enlarged prostate. What device might we have to place as nurses? An indwelling Foley catheter or a Foley catheter, right? Let's say there's a big stone obstructing urine. They might need a ureteral stent. Let's say the stone's caught up in the ureter. It's stuck there, blocking urine, which is now backing up into the kidneys, causing damage. So we might need a device to alleviate obstructions, especially in our post-renal causes. Dietitian as needed. A lot of clients with acute kidney injury can absolutely be at risk for malnutrition. You need to be looking at their protein and seeing what the kidneys are doing in terms of filtering protein appropriately or not. So dietitian as needed to regulate diet. When I talk about chronic kidney disease, we're really going to go into diet because that's very important. And then treatment of electrolyte and acid-base imbalances as needed. Let's look at this. Let's say we started our intervention. Let's say we had a client that, was hemorrhaging, or a burn client, whatever reason, and we now have pre-renal causes that led to a lack of oxygen to our kidney, causing kidney damage. And our potassium could be super, super high. Well, they might, even though they're not diabetic, they might get insulin. Y'all remember back to pharmacology, insulin has the ability to take potassium from the blood and transport it back into the cell to decrease serum potassium levels. They might have to get sodium pyrethrostrine, aka K-exolate, so the medication can bind to the potassium and we can excrete it from our bodies. So there might absolutely be treatment for these abnormal electrolyte levels, such as hyperkalemia. Acid-base imbalances, you're in metabolic acidosis. You might need to give them sodium bicarbonate. So if you are not understanding metabolic acidosis, review the video I have on that. It will explain why bicarbonate levels are low. It will explain why also acidosis increases potassium levels as well. So we might have to give them sodium bicarbonate. And then dialysis. Dialysis is always a treatment option for kidney failure. This will never be your first go-to. This is if we know our cause, we know our trigger, the interventions we're doing are not working, we might have to dialyze them and filter their blood for them using a machine. So I have a video on dialysis in the future, but that's a whole nother entity you need to understand as a nurse, okay? So a lot of different treatment. Your treatment is dependent on the cause, and we better make sure that we're intervening in the oliguric phase, because that's when your symptoms are presenting. So once they have their symptoms in the oliguric phase, once we treat them appropriately, they start to pop into the diuresis phase. I want you to think diuresis phase is the phase of healing. It's when the kidney is starting to repair itself. It can last for weeks, this diuresis phase. So that's when urine output increases as the kidneys start to heal. So whatever assessment data you had in the oliguric phase, let's say they had a nephrotoxic med given to them causing intrinsic kidney failure, and they went into, they had minimal to no urine output. They started showing all these signs of fluid volume overload. So they had crackles in their lungs, shortness of breath, edema, weight gain, jugular vein distension, all those things. Whatever symptoms pop up in the oliguric phase, in the diuresis phase, we want to see those symptoms resolve. So for that client, let's say we diuresed them rapidly. We gave them furosemide. You want to see a decrease in weight. You want to see a decrease in edema. You want to auscultate clear lung sounds if they had crackles in them. We should see an increased urine output, and we should start to see the symptoms from this phase minimized in your diuresis phase as the kidneys start to heal. And the last phase is your recovery phase. So this is when the urine returns back to normal. I do need you to understand, dependent on how the kidneys healed, how well the kidneys healed in this phase will result in the outcome in this phase. Because if they have acute kidney injury, it can absolutely lead to chronic renal disease if the kidneys resulted in permanent damage, okay? So the recovery phase is dependent on how well did the kidneys heal, but their urine output should normalize. All the assessment data that you gathered in the oliguric phase should be normal. We should start to have, our orientation should be back to normal. We shouldn't be so weak and lethargic or fatigued, okay? And something I forgot to talk about in the diuresis phase, just because their urine is increasing, they're losing a lot of volume. They're losing their fluid. So there's always a risk of fluid volume deficit in this phase. So they're diuresing, the kidneys are healing, the kidneys are coping, but really look for signs of fluid volume deficit. Look to see if their blood pressure is going too low, heart rate's starting to go high. Look and see if they're having any signs of dehydration, because you might have to give them a lot of fluids to sustain them in the diuresis phase, okay? So, throughout this whole process, I know I don't have enough room on this board. We're gonna talk about how you diagnose this disorder on the back, but you need to think evaluation. What do I need to be looking at once I treated my client to ensure that they're not having further problems? With our treatment, you should be monitoring all lab values. Everything from BUN, creatinine, GFR, all the electrolytes that could have been abnormal, the ABGs if they were in metabolic acidosis, to see them normalizing. You need to be looking at vital signs. If they were in fluid volume overload in the oliguric phase, their blood pressure should start to come down once treatment works. You need to be looking at daily weights. I know in your NCLEX style questions, if there's a right here, right now acute problem, daily weight is never your answer. It takes too long, right? It doesn't help us right here, right now for assessment data. But don't forget, daily weights are the most accurate indicator of fluid volume. So they were in fluid volume overload in the oliguric phase. Let's say we diuresed them for our treatment. We want to see their weight start to decrease. That shows that it's working. So vital signs, labs and electrolytes, your daily weight, your general physical assessment, of course, head to toe assessment. And we also better be looking at their intake and output, specifically their urine output. Always, always monitor their urine output in acute kidney injury. Those are things you just need to be utilizing for evaluation. Did our treatment work or did it not? Okay? So remember I told you we're going to do 2 critical thinking questions, but before I get into that, I want you to look about how we diagnose it. Just so you know, when they come in with symptoms of the acute kidney injury, to actually diagnose it with that disease or that title, it can be done doing a lot of things, utilizing a lot of things. So lab values, urinalysis, ultrasound. They can ultrasound the kidneys to see what's going on. Biopsy. A lot of times they might have to do a kidney biopsy if they just cannot figure out that intrinsic kidney problem. It has direct kidney damage and they don't really know what's going on. They might need to get a kidney biopsy to verify the problem. So treatment can be most effective. So that's just your diagnostic tools for acute kidney injury. I could not fit them on the other side of the board just to let you know. But now we're going to do these critical thinking questions. Before you even read it, remember your NCLEX style questions, your priority questions, anytime you see first, best, initial, most, priority, that means we can have multiple answers. I want you to know we can do every single answer choice to this client. We can do these things in the real world, and why it's so frustrating, these NCLEX style questions, is in the real world we are doing all answer choices all at the same time. But the NCLEX needs to understand, if you can do one thing and one thing only, did you do what would help them the most in this moment in time, the best in this moment in time, okay? So always make sure you follow ADPI. A lot of these assessment questions focus on assessment versus intervention. If you don't know how to break down NCLEX style questions yet, I have a video for you to review. It's called, I think, Breakdown of NCLEX style questions. It will really help you kind of just go through this process, but I'm just going to do it quickly. Step 1 is to identify your topic and underline the type of data that you have. And if you can see, I have the same exact answer choices for both clients, but dependent on their assessment data, it's going to lead to a different answer choice, okay? So let's read the first one. And I had to abbreviate for lack of room. Always remember in NCLEX style questions, everything will be written out for you and abbreviation will be followed in parentheses. So you don't need to worry if you don't understand abbreviation. It was just because of lack of room on the board. So a client arrives to the emergency department post-MVC. So they had a motor vehicle collision. The nurse inspects. I always underline my assessment data. The nurse inspects, meaning us. We are the nurse in this question. No visible signs of bleed. So this is a low blood pressure, high heart rate, skin is cool and clammy, urine output is 15 mLs in the last hour. That is never good. Now they have elevated BUN and creatinine level, which is showing kidney problems, and a low hemoglobin and hematocrit. That's never the appropriate abbreviation, but a low hemoglobin and hematocrit level. There is a lot of assessment data here. So you need to start picking apart, first off, do I need to gather more data? Remember, you never assess. You never pick a nursing assessment answer if you have a right here, right now problem. And to me, I'm reading a lot of right here, right now problems. So let's start to look at them. We have a low blood pressure, a high heart rate, skin is cool and clammy, low urine output, elevated BUN, and a low H&H. So if I highlight these components, look at it, low blood pressure, high heart rate, cool and clammy skin, low urine output, and an H&H. I'm not going to worry about this BUN and creatinine right now because let's think about this. This is showing a right here, right now fluid volume deficit. I put a check if I need to find an intervention answer. I have a right here, right now circulation problem. I need to find a circulation intervention. I'm not saying their kidneys aren't hurt. Their kidneys are hurt. Look, you can tell their kidneys are damaged or hurt because of the low urine output and the elevated BUN and creatinine. But let's think about it. According to Maslow's, is kidney damage or right here, right now circulation your priority problem? For this question, my priority problem is circulation. Circulation trumps kidney damage all day. And remember, it looks like this client's hemorrhaging. Not that I don't care that they don't have signs of bleed, but everything else, the low H&H, the low blood pressure, the high heart rate, the cool and clammy skin is showing that this client is bleeding. So, if I can only do one thing, I'm going to find a circulation intervention. And remember, in NCLEX style questions, if it's in the answer choice, you already have the physician order to do so. So don't wait for a physician order. It's assumed you have that physician order to do so. Remember, it always has to be in your scope of practice though, okay? So I'm gonna look for a circulation intervention. This is assessment. This is an intervention, this is an intervention, and this is an intervention. And remember, assessments just gather more data, which we don't need. I know it would be good to know their pulse ox level. I know that. And it's so frustrating for students because you're right. It would be good to know their pulse ox. We might need to put them on oxygen. But think, in these NCLEX style questions, if you assess the pulse ox, you're trying to find another problem where you have problems you need to fix already, okay? So I know I need an intervention answer. I can get rid of one. Now let's see which one is related to circulation, more specifically fluid volume deficit. So inserting a Foley catheter is for kidneys. Administering fluids is for circulation. Administering a diuretic is for kidneys. We should, if we can only do one thing and one thing only, for this client, give them fluids, okay? Give them fluids. On this end, let's look. A client with a history of BPH, so they got BPH, arrives to the emergency department. The client states, I have not peed in 24 hours. Always, always pay attention to client quotation marks. The client is telling you their concern. Yes, it's subjective data. I know that. We cannot act on that alone, but they're gearing you towards their problem, okay? The nurse assesses bladder distension and a bladder scan result of 1,200 mLs. Oof, that's a lot. If y'all don't know what a bladder scan is, it's a little non-invasive device we can do as nurses. You put a little jelly on their bladder and it almost looks like if you've been pregnant and you've assessed a fetal heart tone, okay? Very similar. But it kind of scans the bladder from the outside to see how much urine you're holding. Just so y'all know, for instance, a post-void residual, if I pee and I scan my bladder, there should not be more than 100 mLs in there. The fact that this guy has 1,200 mLs in the bladder, that's more than a liter in his bladder. There's a problem. So let's look at our problem. No pee, and we can't act on that data, but bladder distension and 1,200 mLs in their bladder. And they also have a history of BPH. So there's no need to gather any more data. You have enough data, right? So you can act. I always put a check if I have to act, but my problem is urinary obstruction or urinary retention, however you want to put it. So you need to look for something about urine. That's an intervention. So this is assessment, intervention, intervention, intervention. All the same things. Get rid of your assessment. This is for circulation, that's for urine or your kidneys, and this is more so for the kidneys. So now you can get rid of your circulation answer, but let's think about this. If we can do one thing and one thing only, are you going to give a diuretic, which you cannot prove will get the urine out because it could be a urinary obstruction, or are you physically going to use a device that we know can get urine out? Okay? So your best answer is to insert a Foley catheter into this client to alleviate all that urine that's sitting in their bladder, causing elevated BUN and creatinine levels, because this is important too, but we got to think about why our kidneys are being hurt. Why are they damaged right now? So I really hope this helps you. Remember, acute kidney injury, you need to think about what is the onset, what is my cause. It will determine your assessment data, and it will also determine your nursing interventions, okay? So good luck critically thinking. Make sure if you understood this, help somebody else so we can all be successful. All right, take care.